The Prevention and Management of Occupational-Related Low Back Pain by Brittany Holmes, Myela Martinez, Caleb Meldy, and Matt Geringer. According to DeLito et al., current literature does not support a definitive cause for initial episodes of low back pain. Risk factors are multifactorial, population-specific, and only weakly associated with the development of low back pain. In 2010, back injuries made up almost half of all musculoskeletal disorders in U.S. occupations. Shaw and colleagues found 7 workplace variables associated with low back pain. Those were heavy physical demands, ability to modify work, job stress, social support, job satisfaction, return to work expectation, and fear of re-injury. DeLito and colleagues found that low back pain was prevalent among 39% of blue-collar workers and only 18.3% of white-collar workers. Conflicting evidence exists for a gender bias associated with low back pain. While low back pain is relatively common throughout adulthood, years 35 to 44 are the most common for low back pain. In 2010, the Bureau of Labor Statistics found that the highest occupations with low back pain were nursing aides, orderlies, attendants, and registered nurses. When it comes to symptoms, Walker et al. Found that movement or activity-related symptoms are usually related to mechanical low back pain, whereas pain at rest is more indicative of inflammatory low back pain. Looking at prevention and treatment options, in 2011, Schaafsma and colleagues published an update of a Cochrane review from 2003. They were interested in comparing the effectiveness of physical conditioning programs and reducing time lost from work in workers with low back pain. They used only randomized controlled trials that included workers with disability-related low back pain and were included in a physical conditioning program. They defined work hardening as exercise related to the demands of the job, exercise that was intended to improve one or a combination of these systems, or physical conditioning intended to improve work status. And usual therapy was defined as traditional physical therapy treatment. The authors found that there was no difference between a work hardening program and the usual therapy for decreasing disability in workers with acute low back pain, and that an intense physical conditioning program has a small positive effect on sickness absence compared to usual care at 1-year follow-up in patients experiencing chronic low back pain. The authors also found that physical conditioning with cognitive behavioral therapy was no different than physical conditioning alone. This is conflicting with the conclusion of the first review. They also found that when the workplace was involved, there was an average of 45 fewer sick days in workers with low back pain. Verbeek and colleagues also published a review in 2011 that was an update of a Cochrane review from 2005. They included 9 RCTs and 9 cohorts, basing their conclusions solely on the RCTs. They looked to determine the effectiveness of manual material handling advice and training and the use of assistive devices in preventing and treating low back pain in workers. The authors concluded that manual material handling advice and training, with or without assistive devices, is similar to no intervention, minor advice, professional education, exercise, or back belts. So what does this all mean? We are doing a poor job of managing and preventing occupational-related low back pain, and more research is needed to help us improve preventative and treatment strategies. Schultz and Ekholm investigated the agreement between ICF core sets and the functional capacity valves that are currently used. They assessed the domains of body functions, body structures, components of activity and participation, and environmental factors. Schultz and Ekholm also found that on-site examination provides more information than those FCEs. Guterberg et al. Concluded that FCEs needed more research to determine their reliability. Therefore, a clinician could conclude that occupational-related low back pain is best treated as non-specific low back pain. And we know that non-specific low back pain can be treated through the treatment-based classification system. From the clinical guidelines published in the 2012 April JOSPT, DeLito outlines 2 categories for examination: physical examination and mental impairment measure. The physical examination is made up of the lumbar active range of motion, segmental mobility assessment, pain provocation with segmental mobility testing, centralization during movement, prone instability test, aberrant movement check, straight leg raise, slump test, trunk muscle power and endurance testing, and passive hip ranges of motion. The mental impairment measures includes the FABQ, OMPQ, PCS, and STAR-T screening tools. The categories set forth by DeLito and colleagues in their clinical guidelines look a lot like the treatment-based classification models categories. They include low back pain with mobility deficits, with movement coordination impairments, with related lower extremity pain, with radiating pain, with generalized pain, and with cognitive or affective tendencies. As far as variables that can help predict favorable or unfavorable outcomes for patients, these three studies by Mello, Hayden, and Gages have helped determine several prognostic indicators. Beginning with this cohort study done by Mello and colleagues in 2011, subjects were assessed addressing occupational, psychological, biomedical, and demographic lifestyle factors. Measurements were taken at baseline and at 6 months after a first episode of acute, subacute, or recurrent low back pain. The results of this study showed that subjects with resigned attitudes towards the job increased the likelihood of persistent low back pain at 6 months, while subjects who experienced social support at work decreased the likelihood of persistent low back pain at 6 months. This table, taken from the Mello study, shows the odds ratios for predictive variables. As you can see, the odds ratios just above 1.0, functional limitations and duration of low back pain, proved equally likely for persistent low back pain at 6 months. You can see also that the odds ratios of the resigned attitude towards the job and social support at work are well above and below 1.0 respectively, therefore showing their increased and decreased odds of developing persistent low back pain at 6 months. In 2009, Hayden and colleagues systematically reviewed 17 low back pain prognosis reviews from 2000 to 2006 and found that among these reviews a small number of prognostic factors were consistently reported. The factors that were consistently reported to be associated with poor outcomes in acute or subacute low back pain are depicted in this table taken from the article. It is important to note that the factors for work and social environment were among those consistently reported. Also, other factors that were reported inconsistently were not included in this list. In 2008, Gages and colleagues published a randomized clinical trial that looked at the effectiveness of different interventions in returning subjects to work. This study randomly assigned 34 subjects who were unable to return to work following work-related low back pain, who also had scores of 50 points or higher on the FABQ. The subjects were either assigned to the comparison group, which only received traditional physical therapy intervention, or to the education group, which received an education pamphlet called the Back Book in addition to PT. This study demonstrated that the education group had significantly better results over the comparison group, with 100% of the subjects returning to regular work duties in 45 days or less. This table also shows that subjects in the education group took an average of 19 days to return to work, while the comparison group took an average of 35 days. And so to conclude this presentation, I leave you with this bottom line summary. Occupational-related low back pain is a vast, multifactorial, and complex issue without evident causality. Therefore, the treatment-based classification approach is the current best option for the diagnosis and treatment of low back pain. Currently proven preventative measures have yet to be determined. Thank you, and I hope you have found this information useful, and have a wonderful day.